kind of put people in two batches of vaccines, either you're pro-vaccine or you're vaccine hesitant. And what we found is there's a whole bunch of people in the middle that are these vaccine, I call them vaccine apathetic. They don't really have a strong opinion, but because of it, they don't really want to be inconvenienced to go get it. So whatever you're at in your local market, if you find an opportunity to get vaccines in front of a large group of people, take it.
Being dismissive of concerns is never really effective. And so it's easy for us as clinicians to kind of quickly get to that point of just wanting to dismiss it by saying that's not true or the evidence doesn't support that. But taking a moment to really acknowledge the concern and fear that the person has, to establish that rapport and establish that trust so that the person feels that they're being heard and seen and respected is much more effective.
I think a lot of our community, they don't really understand what the other long-term effects of COVID are. So I share with them about COVID fatigue and how the lungs change for many patients, and how there's super healthy people who they're still tired and they had COVID a year ago and they haven't been able to go back to work, and how there's an increased risk of heart disease by 20% if you've had COVID. And those things are really scary to people, just not being able to be themselves.
I really think that it comes down to just connecting with their patient and really just, I had a patient yesterday, for example, who, he's been drinking a lot. He had gallbladder surgery and now, he's finally over his surgery. And I said, oh, well, did you get the vaccine? No, I've been waiting to recover more. I'm like, it's been 2 months since your surgery. What are you waiting for? So, I told him your liver is not great. You have other comorbidities, and I really think it's important for you to get the shot. And, my cousin just passed away from COVID. His family is devastated. I really want you to get it. And I think just having that connection and also sharing a personal story about either a patient or a family member, just connecting with a patient is powerful. And I think that can really, really make a difference.
And I do share, we as medical professionals, we can't really predict which patients are going to be the sicker post-COVID versus not. And that's not information that is being shared in the media about the post-COVID syndrome. And we have a lot to learn as a medical community about how to take care of these patients. And they would be the ones that we would be learning on if they were to get COVID. So a lot of patients do think about that, like, well, I didn't know it wasn't just about deaths. I didn't know you could also have long-term effects from COVID. So that actually usually speaks to some people.
Over time, I have found that most of those parents can get to a yes if you talk to them more about this being a risk reduction and increasing safety. So instead of, I'm going to prevent your child from dying of meningitis, meaning shifting a conversation to, I'm going to give you a tool that's going to help protect your child, reduce the risks of harm to your child so that your child can fulfill their full potential in life. It's a much more positive message.
They want a family member. They don't have that other person that's telling them to go get this shot. That's us. That's us for these patients, and we need to fulfill that role and do the right thing.
Let's do some introductions, and I'm just going to call out the folks I see on the screen. So Julian, do you want to start, Dr. Mitton?
Sure, thank you. Julian Mitton, System Director for Population Health Policy at CommonSpirit. I'm an internist and addiction medicine specialist. Thank you.
Dr. Nagle.
I'm Dr. Nagle.
Sorry.
I'm a full-time family practice doctor in Santa Cruz, California.
Okay, and trained at the Southwest Washington Medical University Residency Program?
Yes. Graduated 2010 and have been practicing in Santa Cruz and providing Suboxone therapy since then.
Great. Yeah. Dr. Moulin.
Thank you. I'm Aimee Moulin. I'm an emergency physician. I'm also boarded in addiction medicine. I practice in Sacramento at UC Davis, and I'm part of the California Bridge program.
Great. And you completed and established a health policy fellowship at UC Davis. Is that right?
Yes, I did. I'm no longer in charge of that. I've passed it on, but yes.
Nice. Okay. And Dr. McGinn. Let's see, Tom, you're on mute there.
I'm trying to get off. Okay, sorry about that, everybody. Well, I'm Tom McGinn, Executive Vice President for Physician Enterprise, and excited to listen to our conversation today. First time we're not doing a COVID topic in a while, so although it is very related, and I think, as we all know. Thanks, Gary.
Okay, great. So I just want to remind folks that September is SAMHSA's National Recovery Month, and we have been trying to kind of look at what's on the calendar and then focus some of our talks around these kind of national initiatives. This is an important one. Recoveries for everyone, every person, every family, every community. And so there's lots of work to do here. And so we're going to start with Dr. Moulin, who's going to talk about some of her work at UC Davis, and then with Dr. Nagle. So Aimee.
Thank you. And you can go on to the next slide, but just to let you know, I'm Aimee Moulin. I'm actually with the California Bridge program, of which Dignity is a really fantastic member. So a lot of your hospitals are engaged in this work and have really been examples. And so what we have seen in California on top of our COVID epidemic, which I know you guys have been talking about, is overdose. For a long time, the rest of the country was really beating California in terms of overdose, that there was an epidemic of fentanyl in most of the country, and we were behind here in California. The pandemic changed that. California is now meeting and exceeding everyone's expectations. We have the highest growth in overdoses, the highest rates of fentanyl seizures. And if you look at this graph in terms of drug overdose deaths, you can kind of see our line here in California. We were bumping along here well below the rest of the United States. And after the pandemic hit, and this only goes through halfway through of last year, but this line has gone straight up. And a lot of the growth in overdose deaths we have seen in California. And, it's even the thing with fentanyl is, I didn't know this, but I learned from a patient we recently had, a 17-year-old who had overdosed 4 times in the previous 6 months. His mom said to me at one point, she said, she had Narcan at home and she had reversed him. And she at one point turned to me and said, is there just something we can give him to stop this from happening? And I sat for a moment, I was like, yeah, there is. There's something we can give him. But he was getting it, and I don't know if you know this, but you can get fentanyl off of Instagram. So part of us are thinking everybody is shut in at home, and how are you accessing all this fentanyl when you're stuck at home? But it actually will come to the mail with Instagram. So just to let you know that this is out there and highly accessible. Let's go on to the next slide. I talked to a lot of people. I trained at LA County, and at that time, we didn't think about opioid use disorder or opioid withdrawal as an emergency. But this is a study that really changed so much for me. And this looks at people who are in an emergency department with a non-fatal overdose and followed them through time. And what we learned is that after a non-fatal overdose, this includes my 17-year-old, your risk of death at 1 year is 5%. And most of those deaths happen in the first month. And actually, there is a spike at 48 hours. And so now what I have as an emergency physician is someone who has an increased risk of death, an increased risk of short-term death. So I discharge that person and they're at increased risk of death at 30 days. And I have something that I could give them to prevent that. All of a sudden, this really starts to feel like emergency medicine. Let's go on to the next slide. And so what we kind of have changed this is an emergency, and I can prevent a death by giving someone medication and starting treatment now. And so what we're talking about today is how we can provide that rapid, upfront, evidence-based treatment in our emergency departments to really save lives. Because what we know about buprenorphine is that it is really life-saving and that we're able to prevent deaths by just starting buprenorphine. Go on to the next slide. And to put this in the context of emergency medicine, like what do we need to do to treat? Our numbers needed to treat to save a life. And for warfarin or steroids in COPD, we're looking at a number of 10 to prevent treatment failure, 25 to prevent a stroke. But the number needed to treat for buprenorphine to keep someone in treatment, to keep them from overdosing, to get their life back is 2. And so then I start to feel like, okay, this is really, if I put it in the context of everything else that I am doing in emergency medicine, becomes a no-brainer. And so this is why I really feel like this is something that we should be doing in all of our hospitals. And I have to say, I've been really proud of the Dignity system who's really embraced this and recognized that we have such a huge role in reaching people and being that lifeline and saving their life. We can go on to the next slide. Okay, and so buprenorphine is scary, right? There was this X waiver, and anything that has an X in it feels very scary and it feels like it was illegal. The X waiver was required, well, the X waiver is required to prescribe buprenorphine. You do not need an X waiver to administer buprenorphine in an emergency department or in a hospital. So everyone right now can start buprenorphine in the hospital, in the ED, on OB. If you want to know how, we have a ton of guidelines for California Bridge. You have a ton of guidelines through Dignity. I'm going to show that at the end, but this is really easy to do. And even better, now to get an X waiver, you only have to register with SAMHSA. So everyone with a DEA just fills out a form to register with SAMHSA and you can get an X waiver. I have a video. Previously, the training for X waiver was 8 hours, and I have a video that is 8 hours in 8 minutes, and it will teach you everything you need to know about registering with SAMHSA and starting buprenorphine in, actually it's less than 8 minutes, it's 7.5, because I know everybody has about a 5-minute attention span. So really just wanted to kind of reinforce that everyone with a DEA at this point should be registered with SAMHSA, and that would allow you to prescribe buprenorphine. We can go ahead to the next slide. And what we are doing at California Bridge, and many of your hospitals have a substance use navigator, because as we know, one of the challenging pieces is really linking someone to treatment. Because although we want to get them started, get them engaged in treatment now while we have them, it's really that connection to treatment, which is key. And so a lot of our hospitals, particularly your Dignity sites, have someone who is designated to help us identify patients, help to connect them with outpatient treatment, and to really facilitate all of the barriers that are in place in terms of getting into care. And so all we need to do really to save lives is to just take those 5 minutes to start someone on treatment and refer them to the substance use navigator. You can go into the next slide. And so these are my resources. So this is the California Bridge resources that has probably too much information in terms of how to start buprenorphine. Here, there will be a link to my 8-minute video. There's link to ED quick start guides. So I highly encourage you to check it out. You also have some Dignity specific websites. But I will say, as a ER physician, this is actually one of the most gratifying things that I am able to do, because it has changed someone who is withdrawing from opioids to this problem that I can't fix, this person who has a disease that I have no way to intervene, this really uncomfortable interaction, to someone whose life I can save and change with an oral medication that I can give in fast track. So we have now been able to change opioid use disorder to like a nursemaid's elbow. This is a fixable problem. So I really encourage you to check out these resources. And then I have on the next slide a link to your Dignity director. So Alicia Kurtz, she is fantastic, and she is your dignity specific champion. So you can reach out to her with any specific questions that you have. I know that was a lot, but I tried to get it all in a short period of time, and happy to answer questions now or at the end. Thank you.
Great. And I do want to mention there's a Q&A box on your Zoom. And if folks want to put questions in there, we will answer them during the panel. And if for any reason they don't get answered, we will send out the information. That was a spectacular summary, and we will publish your slides and all the links and all those things that go with it, as well as the link to the video.
Thank you.
Thank you. Dr. Nagle. Oh, Jackson, you're on mute.
All right. So thank you for having me. I was asked to talk about my experience prescribing Suboxone, as an outpatient family practice doctor for opioid treatment of opiate dependency. So I got exposed and started with Suboxone early. I went to the Southwest Washington Medical Center family medicine residency program, which is right across the Columbia River from Portland, Oregon, in southern Washington. And, heroin hit that area early. And so I was there from 2007 to 2010. And some of my faculty was prescribing Suboxone. And I did, as one of my senior electives, a rotation with an outpatient doctor whose practice was primarily Suboxone treatment. So as soon as I graduated residency and came to Santa Cruz, California, I got my X waiver. And, just as Dr. Moulin was saying, Moulin, is initially there was a lot of even peer criticism or fear, or just there was something that was weird, and people were like, well, what are you doing? And you're bringing drug addicts to the clinic. And, it was kind of an odd thing to be doing. But my experience from the very beginning has been that it's an enormously rewarding aspect of my practice, that, you get to completely turn people's lives around. I have patients who will share with me, hey, who I have on Suboxone, and they're very proud. They say, hey, Dr. Nagle, I bought my kids, because we're in Santa Cruz, California with the boardwalk. I bought my kids season passes to the boardwalk this year. Like they're re-engaging with their family, they're doing things. And, and the other thing is working with people who are opiate dependent is incredibly easy, because there's sort of two categories of people. There's drug abusers, and it isn't what you would think. It's very straightforward, and people who are abusing heroin or pills they're buying on the street are in many ways easier than my chronic pain or Purdue or iatrogenic associated opiate dependency patients, because they just come in and they say, hey, I am addicted to heroin. And I put it like this, and I go, rad, I can help with that. And so I give them Suboxone, and they stop taking heroin, and they go, it's amazing. I'm not having cravings or urges or thoughts of using. I don't wake up in the middle of the night dope sick. I'm not waking up with using dreams. And, patients, they get back to work, they get back to exercising, they get back to doing health activities, they get their chronic hep C treated. I've developed this really tight relationship with local infectious disease doctor. I'm sending them all these hep C patients. They're being good citizens, they're paying taxes, and it's just enormously satisfying. And the chronic pain patients, or the long-term opiate pill patients, some of them on high-dose opiates since the 80s, they're a little more challenging, because often they really believe in their pain. And there's often a real pain component, but I can't tell you how many people I've had who, they come in, they're talking about, oh, my complex regional pain syndrome. And, they're kind of like this, and they've got that opiate frost on their face, and they're just not responsive, and I'll get them on Suboxone, and within 2 or 3 months they're sitting up, they've got light in their eyes, the skin color has come back, and they're going, oh my gosh, I can do simple math in my head again. And they'll say, I can't believe where I was at all these years. It was just the opiates talking. This is amazing. Why isn't everybody doing this? Like, why did my other doctors leave me on this for so long? And just again and again and again, I've had these experiences where people's chronic pain turned out to be, yes, 5 years ago, they had an accident, head of the femur was blasted through their acetabulum. Yes, it was bolted back together, but the chronic pain since then was really just about the opiates, and put them on Suboxone and it just goes away. So, I just can't say enough good things. And, even now I'll talk to people and they'll say, oh, well, I wouldn't want a panel of patients like that in my practice. And I have to say, treating people for opiate dependency and meeting with them, monthly, for check-in visits and how are you doing, it is the easiest part of my day, because people come in and I say, how are you doing? And they say, great, this is spectacular. Thank you so much. And, we'll take care of any other health related issues that come up. And in my life, in my practice, it's positive. It's no more of this game of, oh, doctor, my pain and I had to take too much, and oh, I spilt it down the sink again. And all of that is gone. It's just easy, easy, easy. And, so I can't recommend prescribing Suboxone enough. I think it was very harmful in the beginning that we had to have an X waiver, and the DEA was going to come and audit the chart, because frankly, if we're allowed to prescribe fentanyl lollipops and we can prescribe oxycodone, and we don't need a special DEA number for that. So why do we need a special DEA number to prescribe Suboxone? The whole thing is kind of silly, and it's extremely easy. It's easy to get started. It's safer. Your patients you're not going to have to worry about them overdosing, because Suboxone is only a partial agonist, and it's extremely difficult to get into trouble with Suboxone. And there's really no downsides. I only see enormous, enormous upsides. So I can't recommend it enough. And I think that's what they wanted me to tell everyone.
That's great. Thanks. Jackson, do you have any idea how many folks you've treated?
Oh, I do keep track. I tend to hover at any one given time somewhere between high 50s to mid 70s. But, over the years, hundreds and hundreds and hundreds of people. I graduated 2010, so I'm pushing on close to coming to 12 years of treating people with Suboxone. And, many people, and people will cycle back through, like they'll move back to Santa Cruz, or, they'll get off Suboxone, maybe, then they'll do well for a few years, and then maybe they'll relapse and I'll see them again. But probably upward of more than 1,000 different individuals over this last decade or so.
Yep. 1,000 lives. It's great.
We are starting probably around 40 people every month through the emergency department.
Mm-hmm. Oh, and I wanted to mention that too. I am the Santa Cruz County Dignity Health ER bridge guy. And, initially I thought, oh no, because, the ER will start people and then they will, you have to see them within 48 hours, maybe 72 hours. And so I thought, oh no, is there going to be just this onslaught of people coming into my practice? Am I going to be double, triple booked? And it really hasn't been like that. It's been a very reasonable, very doable thing to be a part of. So I also wanted to allay anyone's fear who was being asked to be a part of the ED Bridge program. And of course, the more people who prescribe Suboxone, the less sort of double booking or schedule problems will come up because of that. But so far I'm one of 2 or 3 people in Santa Cruz County with Dignity Health who are. We have a lot of people who prescribe Suboxone for their patients only. And there's 3 or 4 of us who, I'll take all comers. So I get lots of referrals and that sort of a thing. And it's been very easy, very, very easy.
Gary,
Okay.
before we go to
ahead.
the panel,
Yes.
I didn't know, were we going to the panel or was Dr. Mitton going to say something? I wasn't sure.
Well, let's go to the panel and we'll have Dr. Mitton say something at the same time. How's that?
Sounds good.
So let's move to our panel, and there is one question in the chat box that we'll get to, but if people have more questions, please put them in there. So John, I don't know if there's anything special that you do for the panel, or
Nope, we can go ahead right now. Yep.
Okay, so Julian, why don't we start with you? And I know that there's a lot of programs that through the Pop Health team and the physician, our physician enterprise that you are piloting and starting. Do you just want to briefly inventory those for us?
Sure, I'd be more than happy to. And just right off the bat, I'm sorry if there's background noise. My neighbor has decided to start construction today.
That's pretty quiet.
Well, it might change. So I continue to be inspired by folks across our enterprise who are doing work committed to caring for patients with opiate use. And I'm excited to be part of a team at Pop Health and within the physician enterprise that has been working on a variety of different projects, 3 of which I wanted to briefly highlight here. So one is the MAT Champions or Match Mentorship Program. We know from personal experience and anecdote and from evidence that the X waiver is not the only rate limiting step, and often folks need to have the mentorship to help them feel encouraged to write those first scripts. So what the Match program has done, which was launched in June, is it has connected 6 mentors or champions like Jackson and Aimee with 6 of our folks who are considering about getting their X waiver or are new to their X waiver or thinking about writing those first scripts. And it's connected them through a curriculum over a 6-month period, helping them get the skills and knowledge that they need to feel comfortable in writing those first scripts. So our first cohort is ongoing, and hoping that we'll be able to expand that and offer it to future groups in moving forward. The second one would be our virtual tele-MAT pilot. So, which will be launching at 6 pilot sites across CommonSpirit, where patients with opiate use who are identified in the inpatient, in the outpatient, or in the ED setting as having an interest in being connected to care can be connected to care in an on-demand fashion, working with our virtual selected clinical partner, Bright Heart Health. Allowing patients to get access to life-saving evidence-based care in an on-demand fashion and bridging them to a in-person connection and clinical treatment community. The final program that I wanted to highlight is the Oasis dashboard, which is coming down the pipeline very soon, which is an enterprise dashboard, which will help us track the way in which patients are using, and we are all writing scripts for opiates, including highlighting a need for and where our champions are using MAT. So just a collection of work that I'm excited to be a part of, and I think highlights our enterprise desire to care for patients in an evidence-based and holistic fashion.
Great. Okay, there were 2 questions in the Q&A box. one question that got answered. It was from Dr. Karache in Phoenix, and he wanted to know about limits for patients. And Dr. Moulin answered that with the general X waiver registration. You can treat 30 people at a time. And after a year, you can treat up to 100 patients at a time. So it's pretty similar to the X waiver. I didn't actually realize you could go to 100, so it is up there, and that's a good thing. Tom, any questions for the group?
Yeah, I did. So first of all, I mean, all the work all of you are doing, this is so important work, and it just means a lot to me as being in charge of the physician enterprise and proud to see this work going on. So I came from New York, a large health system in Long Island where the opioid epidemic, there was a major hotspot. And I do, Aimee, I love first of all, as an EBM person, I love seeing your NNT slide and showing us that, finding someone in the ER like that is like finding an MI. Or angina, and it's a precursor to something worse, and we need to treat it like that as if it was just. So 100% agree with you on that, and I assume the same process would play out in primary care. Like if you see somebody who's struggling, I mean, it's an emergency for somebody who could overdose, and I just wanted to say how great I thought those numbers were, and how smart that was to put it that way. So thanks for framing it. What about more upfront screening in both primary care and ER? I was part of the statewide SBIRT program where everyone was screened to walk through the door. And I'm sure you're familiar with SBIRT, where you ask and get these brief interventions. And is that something that's happening, or something we are doing or could be doing?
We can talk about SBIRT in the emergency department. So I think that currently there's no reimbursement for a SBIRT in an emergency department like there is in other settings for primary care. So that's one of the barriers. And I also recognize that there's a huge burden on triage in emergency departments, and people are reluctant to take on more activities.
Another screening tool. Yes.
Yeah.
Yes.
So
no, I get
the tactic that I've used and that I've promoted to other hospitals is this concept of universal offering of treatment. So we will put up signs that say, do you need help with pain pills or heroin? Ask us for help. So I have those signs in my waiting room. I have them at the triage desk. I have them at the bathrooms. And so the goal there is someone who wants help understands that they can ask for help. And what we have found is, I don't know if there's an exact correlation, but my triage complaints for things like migraine or chronic abdominal pain have gone down. And I've seen a rapid increase in triage complaints for heroin withdrawal. So we just made it a safe space for someone to walk up and say, I'm withdrawing. And that's kind of the reverse screening.
Let me just see if Jackson and Julian have any. Maybe I said SBIRT as if everybody knows what that means. So it's screening, brief intervention, referral to treatment, if I got that right. I did it.
That's right. Yeah.
All right. I'm always happy when I can get that. Jackson, is this something that you have any feelings about? And Julian, I'm just curious.
Well, just as was mentioned, another screening activity, there's only so much time in a day. Of course, we should be doing all the screening activities, but we're not. Yeah. It tends to be, it's funny because right now I'm studying for my family medicine boards, and there's an overwhelming amount of screening activities that we could or should be doing. And it's sort of just occurring to me that almost what we need is a big screening activity that, one form, patient asks, answers 2 pages of questions that sort of screens for multiple different things at once. I would love to be doing more of that, but I'm not. And, I screen everyone for those sorts of things at every yearly, physical or exam, but we're not doing that for every patient that comes through the door.
Agreed.
The only other thing I would add is just second what Aimee was bringing up. I think that any chance you have to try to break down some of the stigma around opiate use, and if you're able to frame it as this is a common medical challenge that many of my patients face. It helps build trust, and it also makes it more likely that the patient is going to turn to you in those moments of crisis, whether that's in the ED setting or in the primary care setting.
This has just been great, and I've gotten offline texts to talk about the value of this and how well this was done by both Aimee and Jackson and Julian. And so thank you, not just for doing this, but for all you're doing outside of this video conference. And I think there's a lot to learn, and our hope is that we actually are able to increase our numbers of Suboxone providers. Now, we won't call them ex-waivered providers anymore, but I think there's a huge opportunity for us. And I think Jackson's message I've heard over and over again from folks across the country who do this work, and they end up saying, it's the best part of my practice because people are happy, they're grateful, they feel as though they got something out of their relationship with their provider. And I'm not pulling my hair out, arguing over how many pills I'm going to prescribe at the next refill. So I think this is fabulous. It fits with COVID, it fits with population health, and it fits with all the stuff that we're doing. So I want to thank you guys in particular, all the people who participated. And as people know, we post these videos, and this one we will make a special effort to be sure that it gets out to our primary care practices so that folks can have a look at it. So with that, thank you. Happy Labor Day. Happy Labor Day. That's where we are here. And so I've been practicing this to say, be safe and test negative. So have a great weekend. Thanks, everybody. Appreciate it.